Topic is complete rectal prolapse. Complete rectal prolapse. Dear students, today we'll discuss a condition, a perianal condition, not uncommon, especially in elderly, and more often in female, but do can occur in males also. That is, just see what exactly this is. What is this condition? Look at that. It is a perianal region, anal canal. Something is coming out like this. And circumferential, there is a point which is very, very important. Circumferentially, it is coming out. The word circumferential is very, very important. So it comes almost full thickness. Entirely it comes. So this is nothing other than complete rectal prolapse. What is it? This word is very, very important. It's circumferential descent of rectum across anorectal ring. This circumferential word is very, very important. Remember, there should come in definition. That is how we differentiate it from the piles. Piles has got it is not circumferential. It is localized. It is it got a skin component in piles, where here there is no skin component. Usually in 3, 7, 11 o'clock position, all of you know that. And this is circumferential. In color you can see this is the red. That is actually technically or textbook wise it is called as plum colored piles. Where this is a typical red colored is rectal prolapse. So most important thing is circumferential. That word is very, very clear, very crucial and important. So it can be mucosal and full thickness. It can be partial or complete. And there are differences why you call it mucosal is invariably partial, full thickness is invariably complete. So these are the different types, partial and complete. Partial is less than 3.75 centimeter, usually only mucosal, and you can feel it is only mucosa without any muscular layer that, and length is usually less than 3.75 centimeter, and treatment is for partial digital repositioning. Partial repositioning is quite common in children, and eventually it may become all right eventually if rectal tone, muscle tone, or perianal muscle tone becomes normal, or you may have to give a injection sclerotherapy, sometimes good salt ligature, or temporary wiring and so on. So, or staple transrectal resection surgery, also or STAR it is called. So all the things can be done in partial. Not very difficult to manage. Often may be self-limiting, but it has got enough treatment strategies by intervention, which gives a more or less a cure without much eventual problems or residual sequelae as such. Whereas complete is totally different. It is rather big. A lot of discharge will be there, mucous discharge. Sometimes infection of the mucosa can occur, inflammation can occur, bleeding can occur because of the constant rubbing. It can become irreducible, and it may get strangulated, it may get infected, sepsis can occur, ulceration can occur over the prolapsed rectum when we can't reposition it. It can't go back because of the congestion, venous congestion. It may bleed profusely also sometimes, and common in adult and common in females, common in elderly, very lax anorectal ring, perineal muscles are very much weakened, so needs a definitive procedure, either perineal procedure or laparoscopic per abdomen, or open laparotomy procedures of different. So many types of surgeries are there. It's often asked as a question, MCQ question, short note, management of complete rectal prolapse or surgical treatment for complete rectal prolapse. Abdomen, in that abdomen open, laparoscopic, and perineal, Dillerum's procedure, Ultimate's procedure, all those things are the perineal procedures. Partial, complete, totally different. Complete rectal prolapse, totally different. Meaning-wise, definition-wise may be same, but meaning-wise different. Approach-wise different. So that's why partial rectal prolapse may be asked as a short note. Complete rectal prolapse may be asked as a short note. Rectal prolapse itself may be a main question. Clinical case may be kept rectal prolapse. So all these things are important when you think of rectal prolapse per se and complete rectal prolapse in specific. So what are the causes? Weakening of the sphincter complex, old age, multiple pregnancies, malnutrition, metabolic causes, bedridden patient, neurological causes. So many causes are there which weakens the perineal muscle. That's what exactly happens. Remember, so the different causes for complete rectal prolapse. And so aim of treatment is you have to do some investigations also. You may have to do a discography, you may have to do a colonoscopy, you may have to do a neurological assessment of the perineal area. You may have to examine the spine, abdomen examination may be required. So according to correlation, according to the history, according to the clinical status, you may have to do a further imaging or other tests to find out how much muscle is weakened. So what exactly you have to do in this patient. So this is the aim is to control prolapse. Continence is important. You do all procedure and then the patient is incontinent, doesn't serve purpose. And meantime, once you do procedure, it may cause over treatment may cause constipation also, or sometimes diarrhea also. So over treatment causing constipation will be distressing to the patient. So planning is very, very important. Prevention of constipation after surgery, prevention of maintaining the continence, and meantime treating properly for the prolapse. So those are the three very important factors which is required when you treat a complete rectal prolapse. So defecography, sigmoidoscopy, manometry are told. Pudendal nerve latency test is very important. Nerve weakening is there. How much muscle? Electromyography also sometimes you can do. Which muscles are weakened in the perineal area, in the rectal ring area, and so on. So different treatment I already told. Laparoscopic is a standard one. Perineal Delrum's operation is a very good procedure. And ultimate sigmoidoscopy Wells operation. Different procedures are there. All these things are the MCQ questions actually. Remember, Riftin's operation also sometimes. And so always all those different procedures, you can always read my manual of surgery, current edition, gives in detail about good illustrations, photos, in detail about pathophysiology, etiology, types, and management investigations, and so many procedures, so many MCQs. Questions will ask Viva, it may be asked short case may be kept for PGs and UGs, and oxy may be kept. So it's quite important. Common thing as such actually. One of the common perineal diseases like other fissure in or rectal hemorrhoid, perineal hemorrhoid, and fistula in rectal prolapse, carcinoma. So these are the 5 conditions which you have to remember always when you do a rectal examination. So that is why all these things are important. So please go through my manual of surgery and detailed operative procedure. Also go through my operative surgery. New edition has come, 3rd edition this year 2025, and that also you can go through it with a detailed 2-volume book, step by step. So whoever operating, especially for practicing surgeon and MS students, surgery postgraduates, it will be very, very useful. My clinical method in surgery clearly gives with the video of the rectal prolapse, how to reposition it, and how to examine a rectal prolapse patient to confirm the diagnosis, to rule out piles and other causes for the rectal prolapse. Rectal examination is a must in this patient to find out the sphincter tone. That's very, very important. Lax sphincter tone is a very common entity. That's also given in my clinical methods of surgery. So please, if you got a video, please you can go through that. You can have my book. It gives everything detail about the complete rectal prolapse. Students, answer this MCQ. I acknowledge your answer. I appreciate your answer, and put it in the comment box. Give the answer later. And also request students, please subscribe my YouTube channel, which gives a daily brief lectures on interesting surgical topic, clinical case, images, X-rays, specimens, operative surgery, briefly, incisions, technical aspect, and so on. Briefly 5 to 10 minutes brief lectures for one topic daily. It will be there, so you can always daily go through that for a brief period without much tests, and understand the surgical subject very well. So please subscribe and press the bell, and also share the YouTube with your friends and colleagues. for them also useful to this YouTube as such. And also request you to join the live session once in 2 weeks. It comes with some students, will be some different college will be presenting a case and case scenario with the detailed discussion of presentation like hernia, varicose vein, PVD, breast lump, thyroid, mass abdomen, and so on. And usually 1.5 hours like discussion in detail, clinical examination, interactions. You can also put your questions in the chat box and get the answer. And other than me, senior faculties from different colleges also will join for that. So you'll have a better idea how to present a case, how discuss a case, which is useful, very, very much useful when you present a case, in long case or short case, whatever cases in your practical exam, which is very, very useful. So please join. And also when you join that, whoever joined live will get a certificate of joining, which will be very, very useful for your future career as such. So I request again, join live session and subscribe my YouTube and answer the MCQ. Best-com technique is used in A, B, C, D. Find out the right answer. Answer another MCQ. Barron's banding is done for A, B, C, D, second degree, third degree files, fourth degree files, which are, put the right answer again, get the answer later. And quotation of the day is risky is price to pay for the opportunity. Somewhere you have to take the risk in your profession, life, work, all those things, but without breaking the ethics and principles. So this can be taken without breaking the ethics, with principles, that to create an opportunity to come up yourself and become successful as such, dignified successful as such. So that is a good quotation, especially for surgeons. And again, I request the students, all of you, read my SRB's Manual of Surgery. It contains in detail all chapters as far as oxy is considered: general surgery, endocrine surgery, breast, thyroid, varicose vein, peripheral vascular disease, specialties, urology, cardiothoracic, neurosurgery, and gastrosurgeries, everything, hernia, hydrocele, and urology, and with the instruments, specimens, and quotations, and lot of photos and illustrations and footnotes as such. Of course, recent advances also it is added there. Operative surgery briefly also added, which is useful for especially for undergraduates. So purchase my Manual of Surgery current edition, which is more than sufficient to learn subject very well, surgery, and also understand and reproduce in your theory exam and practical as such. Very, very useful in clinical methods of surgery. SRB clinical method of surgery. Again, in detail, how to examine a patient like hernia, breast, thyroid, general examination, PVD, varicose vein, swelling, ulcer, everything, breast lump, abdomen mass, chronic abdomen, brief orthopedics also, and video of examining the patient of each chapter, which is very, very useful for you, with a lot of photos. Of course, with a table, a differential in a tabular form. And important thing is, but though there is no management because it's a clinical book, it also contains instruments, is important for the exam, specimens, surgical specimens for the exam, and images also for the exam, which will cover your clinical practical exam. So how to examine a patient on each topics, each different areas, in detail it is given. So very, very useful. So purchase my clinical methods in surgery current edition, which I got a video also. So it will be very, very useful for you. Of course, my operative surgery current edition with the 2 volume in detail gives a description of all procedures step by step with around 10,000 illustration and photos. My brief atlas of tissue approximation with the video, 100-page atlas. It gives how to suture do a different suturing, skin, deeper area, laparoscopic, bowel suturing, everything with the videos. Again, very, very useful when you want to acquire a skill also. And again, I request all students to subscribe my YouTube channel, SRB Surgical Insight, and Instagram and other things, so that you will update your surgical knowledge by going through daily brief 5 to 10 minutes lectures. And also request you to join live session and also share channel with your friends, colleagues, so that let them also learn daily surgery without because it is free actually. So please subscribe. Again, request subscribe my YouTube channel SRB Surgical Insights. So students, I hope you have understood this lecture very well. Thank you very much.